Welcome everyone to this evening's webinar, where we will address the question, is OCT the next game changer in margin visualization, sponsored by Perimeter Medical Imaging AI. For tonight's webinar, the presenters are myself. I'm Nina Tamirisa from the Department of Breast Surgical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Maryam Elmi, who is from the Division of Surgical Oncology and Endocrine Surgery from the University of Texas Health Science Center in San Antonio, Texas, and Dr. Stacey Carter from the Division of Surgical Oncology and the Breast Surgery Section, the Baylor College of Medicine in Houston, Texas. So for tonight's agenda, we're going to start by discussing what is optical coherence tomography, which will be referred to as OCT. Start with the introduction to OCT for margin visualization and OCT comparisons to histology. We will then go through some case reviews and discuss OCT with integrated AI and what the future looks like for margin visualization. And we will end tonight with a question and answer session. So the OCT imaging device that was used during the data collection that will be presented in the case reviews today is FDA cleared under a general tissue indication, and this allows for the device to be used on any excised tissue, including breast tissue. The cases that we will review today were part of a multi-site data collection project titled Wide Field Optical Coherence Tomography Imaging of Excised Breast Tissue for Evaluation of the Computer-Aided Detection Tool Image Assist. The three sites involved in this data collection were the MD Anderson Cancer Center, the Baylor College of Medicine, and the UT Health San Antonio Health Science Center. Around 200 cases were consented for across all three sites. Dr. Savithri Krishnamurthy, the Director for Clinical Trials, Research and Development from the Department of Pathology at the MD Anderson Cancer Center, was the principal investigator on this project, which was completed this summer under her guidance and leadership. This AI collection project was funded by the Cancer Prevention and Research Institute of Texas. I will now hand it over to Dr. Elmi, who will take us through some background on OCT and review a case from her site at the UT Health San Antonio.
Thank you all for joining us this evening. I hope that by the end of this session, you'll be as excited as I am about OCT and its potential to decrease the rates of re-excision surgery in our patients. So what is OCT? Optical Coherence Tomography, or OCT for short, is a high-resolution optical imaging technique that produces real-time images of subsurface tissue structures. Perimeter's imaging device uses OCT to produce 2D grayscale images, much like those used by ultrasound. However, instead of using sound waves used in ultrasound, light waves are employed by OCT to produce images of a much higher resolution with an imaging depth of up to 2 millimeters. And this 2 millimeter imaging depth is important for margin visualization as it aligns with our DCIS margin guidelines. With wide field OCT, we can scan specimens up to 9 centimeters wide. Now let's compare OCT to other imaging modalities. OCT has 10 times the resolution of both ultrasound and X-ray, and 100 times the resolution of MRI. As exemplified by images of this nail bed here, OCT can differentiate between the different layers, such as the nail body, nail bed, the epidermis and dermal layers, as well as traversing blood vessels. The resolution provided by OCT allows for the recognition of distinct tissue structures, which we can apply to our lumpectomy specimens. Although the intraoperative application of OCT is novel, the technology has been around in other medical specialties. Developed at MIT, its first commercial application was in ophthalmology in 1996. Today, there are over 30 million eye exams performed annually using OCT. OCT was then adapted into cardiology to examine the coronary arteries in vivo, and there were other applications as well in dermatology and upper GI imaging. Today, we have an OCT device aimed at imaging excised surgical specimens in order to visualize the margins in real time at point of care. You can see here on the left-hand image that OCT can differentiate between healthy and diseased retina within seconds. In the diseased retina, we see a clear disruption in the photoreceptor layers, whereas in cardiology, as demonstrated by the right-hand image, OCT imaging is achieved using fiber optics within an intraluminal catheter. The in situ composition of plaque can be detected in real time, and this has shown to have a strong correlation with histological analyses. OCT can differentiate accurately between whether the plaque has fibrotic type plaque, lipid pool, calcifications, or a thrombotic process. Now within the breast tissue, OCT can delineate the architecture of the excised tissue. The black and white images are OCT pictures captured in real time, and right next to them is the histological correlate in pink and purple. In this cross-sectional picture, image A demonstrates really nicely the ability of OCT to image normal ductal structures within their surrounding epithelium. The next row down, image B, we're looking at a longitudinal view of a normal duct in dense fibrous tissue. Image C is a longitudinal view of ducts and lobules combined. Needless to say, there is no other imaging technology other than OCT that allows for this level of granularity. Here are some more pictures of normal breast structures. From left to right, we see a duct, a simple cyst, and a blood vessel. Again, we see excellent correlation between OCT and the histological image, demonstrating the precision of optical coherence tomography. Now let's move on to suspicious findings within the breast tissue. Here we can see that the duct is dilated and that it has a substantial amount of non-homogeneous content within it, which is abnormal. These findings are highly suggestive of DCIS present at the margin, and this would prompt us to re-excise this particular margin. This figure is looking at several dilated ducts with dense inner content. And this is suggestive of a solid type DCIS with central necrosis. The necrotic core of malignant ducts appear bright with surrounding viable epithelial cells. Again, this would warrant re-excision at this particular margin. Here is another example of DCIS at the margin, surrounded by adipose tissue. This one is a low-grade cribriform DCIS with microcalcifications seen in the OCT image strip, and this image strip matches almost perfectly with its histological image. This margin is in a patient who had DCIS in a background of dense fibrous tissue, showing that OCT is as effective in dense breast. So again, we see a dilated duct here with hyperechoic, non-homogeneous content in it, suggesting that there's DCIS abutting this margin. This case was taken from a clinical study that was published in the Breast Journal in 2019. The patient underwent a localized lumpectomy for DCIS. We can see from the intraoperative specimen radiograph that the clip and wire are centered within the specimen. In this case, the surgeon proceeded to close based on the specimen radiograph. Unfortunately, the pathology report came back days later with a positive margin for DCIS, and this patient was called back for re-excision. The histological images clearly show a large area of DCIS at the inked margin. As part of the clinical study, the specimen was subsequently imaged with OCT, and this margin was detected, delineated by this blue box. It is important to note that there is no presence of calcifications within these particular ducts, so that this would not have been identified on specimen radiograph alone. And this is a wonderful example of how OCT would have saved this patient a second trip to the operating room for margins. So far, we've seen a couple of examples of DCIS on OCT. Now here is an example of an invasive ductal carcinoma at the inked margin. The dense, packed, unorganized cells seen in IDC create a unique effect on the OCT images. The light waves that we use to create the OCT images get absorbed and attenuate rapidly, creating a shallow imaging depth with non-uniform pattern. This next case is one from my own institution. It's a postmenopausal female who was enrolled in the Perimeter clinical trial. She had screen-detected DCIS, and she underwent a bracketed localized lumpectomy for a 4.5 centimeter area of DCIS, and her final pathology came back as medial margin less than 1 millimeter. This is the user interface and what it would look like if you're using OCT in the operating room. We are able to scan dynamically various surfaces or margins of your specimen. The lower left-hand picture, zoomed in now, is the specimen picture, and right next to it is what we call the OCT on face view. The top of the screen shows the OCT cross-sections down to 2 millimeters of imaging depth. You can scroll through these images to review the area, or simply click on any part of the specimen picture below to focus in on that particular area. We will start scanning at the bottom to get an internal view of the lesion and scroll upwards towards the medial margin. Almost immediately, we see some dilated ducts with microcalcifications within them. Again, we're seeing lots of features that are pathognomonic for DCIS at this margin. As we scroll through this volume, we see other areas suspicious for DCIS at the margin. What we're not seeing is any evidence of invasive component, because we're not seeing any features that we would see with invasive ductal carcinoma, such as a uniform signal loss or undulating shadowing. At any point, you can reposition the volume or zoom in and out if there's a particular region that you would want to follow, similar to when we're following a CT scan. Using the measuring tool, we measure the extent of DCIS within the specimen. And this measured to be 4.4 centimeters on OCT, which is concordant with what the pathologist measured it to be at 4.5 centimeters. Now we've selected the medial superior aspect of the specimen. And again, we see areas of DCIS abutting the margin. You can use your measuring tool to measure the distance from the margin. And this measures to be about 0.5 millimeter, thus prompting to re-excise. This case is a great example of how OCT can visualize margins in real time and assess the surgical specimen's microstructure. This can be done in the operating room while the patient is still anesthetized and hopefully decrease the rate of positive margins. It could also be used to assist surgical pathologists with gross sectioning. This concludes my portion of tonight's webinar. We'd like to thank you for attending, and we look forward to hearing your questions.
Thank you, Dr. Elmi. This next case is from the MD Anderson Cancer Center. I'm Dr. Tamirisa. So this next case is interesting as the surgeon took 6 additional shaves, 1 from each margin. 3 margins came back with no cancer and 3 margins came back with cancer, but all 6 shaves actually had negative margins. In the OCT review, we will look at 2 volumes from the gross sections. a negative margin on the primary specimen, and 2 positive margins on the primary specimen. So this first view is of a photograph of a gross section slice with the lesion exposed, followed by an OCT on-fast view, which clearly shows the lesion and its proximity to the margins. The medial margin here is the closest, and this example shows that non-uniform growth pattern of the invasive lesion. And as we scroll up through the volume, we can clearly see a region of DCIS coming up right in here. And it quickly expands into that main body of the lesion, right in there. So correlating that also with the on-fast view, it becomes clear kind of in that region that there's an area of adipose tissue between the main IDC lesion and the area of DCIS, approximately 5 millimeters away. So as we continue to scroll over the lesion, we can get a sense of how close it is to that medial margin. So as we keep scrolling, we can move the specimen and we can correlate it also to the on-fast view as to where we see that area of concern. And scrolling up and down through this, we can see really there's just a separation of about a few fat cells until it touches that medial ink on the margin. So as we continue to scroll through, it's nice to be able to see where this correlates to the specimen itself and on the on-fast view, so you can get a really good sense of exactly where that margin is close. The second gross section that we'll look at gives also another very nice example of the non-uniform growth pattern of the lesion and how it can kind of branch out towards multiple margins. You can see here, like those tentacles that the cancer masses generally have. And when we start to review the cross-sectional images, a satellite area of DCIS will very quickly become apparent right in there. And as we scroll, we can kind of see these very characteristic features of DCIS right in there. And then back to taking a bird's eye view, we can see, correlating it with the on-fast view, that it's about 1 centimeter away from that main lesion. And then again, as we continue to scroll, we can see these classic features of invasive ductal cancer, looking at it on the cross-section, but also correlating it back with that on-fast view. And it's present all the way right up till we get to the top, almost the top of that lesion. We can see more here, that concern for the invasive cancer. And as we continue to scroll through, we get up more to that top of the lesion, like I mentioned, and see these areas of concern as well. And here we can actually still see some examples of DCIS that'll come in here with prominent calcifications. Right in there, you can see a really good example of that with calcifications in DCIS right at the margin. Again, another good example of that is right there. The rest of that looks to be benign tissue. So next, we're going to look at the inferior margin on the primary specimen. The shape from this margin actually did not contain any cancer, so we should expect a negative margin on the OCT. And we can see kind of here from the on-fast view that the majority of this margin is composed of adipose tissue. So scrolling from the top down, we can take a measurement here and see that we get 2 millimeters of just adipose tissue, and quickly scroll down through the margin to get a sense of if there's any suspicious lesions here. But most of it, again, looks like that nice uniform adipose tissue. And here you can actually see a very nice normal duct running through the tissue there, surrounded by adipose tissue. And as we scroll, we can see the remainder of this margin actually looks to be normal. As we keep going through. And then around here, we can see a nice normal duct again. And this is in line with what was seen on the pathology report. So all of that looks to be good. And so we'll now examine the medial margin with the OCT. The medial shave did contain cancer. However, the final margin was negative. So we should expect to see a positive margin on the primary specimen at the medial margin. And here, there are several features at the margin that look to be concerning for DCIS. Again, here we can see a dilated duct. And then as we move forward, another dilated duct there. And then as we scroll, we can see some suspicious abnormalities right in there, looking like DCIS. And then as we scroll down further, we see a duct there, and then we can see a dilated duct kind of lying below a region of adipose tissue. And we can take a measurement of that here and measure it to about 1.2 millimeters. So this really demonstrates the ability of OCT to determine and measure not just positive margin, but close margins for DCIS, which is really helpful when you're dealing with specimens that are just DCIS. And in the on-fast view, we can see the region of interest and how it looks compared to all that surrounding adipose tissue. So we got a good close look at it, but also can see how it correlates to the rest of the specimen as well. Finally, we can examine that posterior margin on the primary specimen with OCT. We'll pull that up here. The posterior shave did contain DCIS, but the final margin was negative. So here we see some regions of interest on the on-fast view. And then by quickly scrolling, we can take a closer look and we see some dilated ducts there touching the surface. Again, here is another dilated duct with some calcifications. And as we continue to scroll, we can look to see if there's any other suspicious there. We see another duct. And kind of some adipose tissue there. And it looks like here we're coming onto another dilated duct with the large calcification as well, and kind of get a better bird's eye view of that as part of the entire specimen. So here is the final pathology report. The patient had invasive ductal cancer with surrounding extensive DCIS, which was evident from the OCT images that were reviewed. And again, like I mentioned at the beginning, this surgeon actually took shave margins all around the specimen. So what we could see here is even at the medial margin, the additional margin taken showed still some evidence of invasive cancer and DCIS. So having seen that on the primary specimen, we can correlate that now with the final pathology here and show that that would have been an indication to have taken more margin. And so these examples really demonstrate the unique ability of OCT to visualize margins in real time and help determine whether margins are positive or negative, this potentially reducing operations and reoperations and taking additional unnecessary shaves. OCT can be instrumental for surgical pathologists as well during gross specimen analysis by providing unparalleled resolution to see microscopic disease throughout the entire specimen after grossing. Now I will hand it off to Dr. Carter, who will be presenting a case from Baylor College of Medicine.
Thanks, Dr. Tamirisa. I'm Stacey Carter, an assistant professor in the Division of Surgical Oncology at Baylor College of Medicine. Perimeter's B-Series OCT with Image Assist AI is currently in development and is considered investigational and not available for sale in the US. Artificial intelligence is becoming more and more prevalent in healthcare. In breast cancer care, AI in radiology is well established and has proven in multiple clinical trials to not only improve sensitivity and specificity, but also can increase the efficiency of image review. The emergence of AI in pathology is making positive impacts and continues to improve as data training sets get larger and machine learning algorithms become more accurate in the field. Looking forward, with the introduction of OCT for margin visualization, a similar approach to AI will unfold. As OCT data sets grow and clinical trials produce evidence to support this technology, we will see AI assisting our surgeries in the not too distant future. When developing AI for OCT imaging of breast tissue specimens, the high-level approach is as follows. Step 1. OCT image data is collected from a wide demographic of patients with the aim to collect a variety of breast cancer features and subtypes. This data, compared to the gold standard pathology and areas of cancer within the OCT images, are labeled and confirmed by a board-certified pathologist. Step 2. These labeled data sets are then fed into proprietary machine learning algorithms. These algorithms work on similar premise to facial recognition algorithms that we see in other technologies. This allows the AI algorithms to then flag similar features in a new OCT data set. With time, and as more labeled data gets fed into the machine learning algorithms, the accuracy should continue to improve. Step 3, the ultimate goal is to use AI to support clinical decision-making in the OR. The Image Assist AI software that was developed using OCT images from the data collection project mentioned earlier will be evaluated in a multi-site pivotal study throughout the US. Dr. Alastair Thompson, Chief of Breast Surgery at Baylor College of Medicine, is the study PI. The study is anticipated to begin in the coming weeks and will continue into 2022. The goal of the study is to evaluate OCT with integrated AI against the current standard of care and assess the impact of reoperation rates for patients undergoing breast conservation surgery. Now let's go to a Baylor College of Medicine case from one of my colleagues. Here's the pathology report. We can see at the arrow we have a close, deep, and superior margin. The first OCT volume we will look at comes from a gross section slice of a lumpectomy specimen, where we can clearly see the exposed lesion with what looks like adequate circumferential margins. We can also see the gross section of the lesion on the en face OCT image, and we will begin to scroll upwards just below the lesion. Quite quickly, we can see in OCT a very pronounced area of invasive ductal cancer. As this is the gross section, we can measure the distance from the lesion to the margin on the OCT cross-sectional image, which in this case is approximately 8 millimeters. Now we will go to the deep margin. Remember, this margin was less than 0.1 millimeters on the pathology report. We will look at the margin to see if we can identify features on OCT. On the en face OCT image, we can see a region of interest in the top left corner of the specimen. When we zoom in on that area, we can quickly identify a feature that is suspicious for DCIS. By scrolling back and forth, we can see this feature on several images, some of which appear to have calcifications in the duct. This area of DCIS is quite small in size and would not be visible with any other imaging modality. The distance to the deep margin in this case is consistent with the pathology report of 0.1 millimeters. From here, we will switch over to the medial superior margin, which was close on final pathology, the medial margin being 0.4 millimeters and the superior margin being 0.1 millimeters. In the en face OCT image, we can see an area of dense fibrous tissue stretching from the medial margin up towards the superior margin. When we zoom in on the cross-sectional OCT image, we can see an area with some ductal structures that looked dilated. As we continue to scroll down towards the medial margin, we can now see clear examples of DCIS within the first millimeter of the margin. Interestingly, we can see this single example of DCIS split and branch off into two different ducts, both of which contain DCIS. Using the scroll function, we can continue to follow those ductal structures further down into the medial margin until we are satisfied that the DCIS is no longer within the margin. Using the measuring tool, we can now measure the extent of this area of DCIS stretching from the superior margin to the medial margin to be approximately 2.2 centimeters in length. We will now switch our attention to looking at the AI Image Assist software, which is entering into a pivotal study this month. For the first example, we will look back at the gross section slice I showed earlier, where we can see the Image Assist software has clearly highlighted regions of interest directly over the main area of invasive ductal cancer. These regions of interest are easily recognized on both OCT images by the blue indicators. Now, let's go back and check the medial superior margin using the Image Assist software. We can see a small number of detections highlighted in blue on the on-face OCT image. There is also a thumbnail view that allows the user to look at all of these detections in one single view. The user can then select areas of concern, which then turn red. Back out to the main viewing window, these selected areas can be quickly reviewed, and we can see the Image Assist software has also found the areas of DCIS in the medial superior margin. Once the Image Assist software is approved, it has the potential to both increase accuracy and efficiencies for intraoperative margin visualization when using OCT. As you can see, this technology can shape the way we approach breast-conserving surgery. With real-time intraoperative assessment, not only can we impact the rate of positive margins, we can decrease operative times, the need to have breast pathologists on standby for margin assessment, which is really only available in large academic centers, and increase patient satisfaction by avoiding additional surgery, decreasing overall healthcare costs.
So thank you to all the participants today who have attended this webinar. We hope you found it helpful. And we will now move on to the question and answer session. Upon registration, there were several questions that were submitted, and we'd like to address some of those questions, the most frequently asked questions today for you. And so we can move on to the first question. One of the most frequently asked ones was, does this apply to margins with DCIS or just invasive cancer? So I'll go ahead and start by answering that question. Essentially, yes. So it does apply to DCIS and invasive cancer. As you saw in the case reviews, it really gives you a real-time assessment of disease at the margin. And so essentially, not just for positive margins, but as was seen, you can measure and see where your margins are close or technically 2 millimeters away for a sufficient margin for DCIS. So it really gives that ability to define where disease is at the margin. And where it gets tricky with DCIS is non-calcified DCIS that may not be seen on mammography as well, and then we get the pathology result and it shows DCIS in the margin. That's kind of the most frequent case that we encounter. But here, as you can see, again, you can clearly identify where DCIS is close to the margins to be able to decide where you want to sort of take directed extra margins at the time of the surgery. And the other instance in which it really helps is in patients who you're really not sure about the extent of DCIS. You have a diagnosis of DCIS with a large degree of surrounding calcifications, but the patient really wants breast conservation. So during the time of the surgery, if you know that your primary specimen contains DCIS, you take an additional shave and that may contain DCIS. You're only going to go so far before you decide to stop, but that can really kind of help in the conversation with the patient, at least initially after the surgery, to say, it looks like we may have a positive margin. We may have to end up going to surgery for either mastectomy or another re-excision, but it looked like it was pretty extensive just based on the intraoperative assessment. So it helps patients kind of understand that you're really trying to understand the margins at the time of the surgery, and it sets that expectation for them as well. So those are cases in which it can be quite helpful too. If anyone else has anything to add, Dr. Elmi or Dr. Carter, go ahead and chime in, but if not, we can move to the next slide, with the next question.
So the next question is, what is the typical learning curve for surgeons with ultrasound experience? Okay, I'll go ahead and answer that. I think the learning curve is actually quite fair. So I did all my training in Canada, now I work in the US. I didn't have very much ultrasound experience. I had some, and then the training for the perimeter OCT imaging device was a weekend course where it was really 2 half days, Saturday and Sunday. And then your first case, obviously, it will take you maybe 10 minutes to go through all the margin images. And then with time, you start, your brain starts, picking up patterns, and the abnormal areas sort of pop out, and the time is significantly reduced.
Yeah, and I can say the same for that weekend training as well. It certainly, after the first couple of cases, it really did feel like your eye just kind of gets trained to see disease at the margin. So you can quickly scroll through once you kind of get used to it to see where disease is at the margin. Plus, you have so many different things to look at. So you have the photograph of the specimen, plus the on-fast view, plus the magnified view. So all those things, I think, really help.
Yeah, I think it takes maybe 5 to 10 cases to feel comfortable. And of course, through those first 5 or 10 cases, you always have the perimeter team sort of on standby or even with you in the operating room.
Yeah, I would agree with everything that you guys said. It's a small learning curve, and the more you see it and the more you do it, it just becomes kind of like second nature. I think we have another question. I'll take this one. How does this compare to current specimen imaging using X-ray? Is it a replacement, or do they work together? This is a great question. So the approach to OCT for margin visualization is very different from X-ray. First, remember, we learned that the resolution for OCT is 10 times that of X-ray. So this really allows us to see microscopic tissue structures far beyond what we're able to see with X-ray, such as DCIS in many of our examples. Another key difference is that OCT only images from the surface down to 2 millimeters. So again, it's ideally suited to be in line with the current guidelines for DCIS. Each margin can be scanned independently, which is another sort of value with OCT. We can maintain that margin orientation. Remember, when we do specimen X-ray, we're really getting a 2D macro view of the specimen with really no specific ability to identify margins. We know from several clinical trials, the sensitivity and specificity of X-ray is quite low when determining margin status. And the presence of calcifications is not a reliable indicator of margin positivity. I'm sure we've all experienced that. In fact, the majority of the calcifications within the breast tissue are usually benign. So this can lead to a lot of additional extra tissue being taken when it's not really necessary. In cases where the calcifications are associated with malignancy, OCT can clearly visualize these areas. It can also pick up microcalcifications within the ducts. We saw that again in several examples. I think X-ray is a really useful tool for wire localization and determining that our seed or our savvy or radar reflector or our mag seed is clearly visualized within the specimen, and we can pick up some of those microcalcifications. So it's useful in that regard. But the OCT image, we're really getting high resolution view of the margins. So I think in reality, we would use specimen X-ray again for the verification of those objects that we're looking for, the clip, a wire or a seed, and make sure that they are removed. But really the value of OCT is looking at margin assessment.
So yeah, I think it comes down to this final question: is OCT the next game changer in margin visualization? Before we address that, I will say we did get quite a few questions on cost, and the cost is very similar to what is currently used for the specimen X-ray devices. But for any further questions, Perimeter would be happy to answer that kind of on a one-on-one basis. And so now to address this final question, which is why we're all here today. From my perspective, I think that artificial intelligence is kind of making its way through all different aspects of life. And if we can kind of get ahead and see where we can apply it in medical technology, that will certainly help us, because I think that it's certainly coming. And I think that this way of having close resolution of the margins to take more directed margins, additional margins at the time of the surgery, lead to better cosmetic outcome. And so to have those answers, to be able to also reduce the rate of having to go back for re-excisions is really critical. So yeah, personally, I think it's going to be a game changer. And with further advances, we can only hope to see more in the future.
Absolutely, I agree as well. I think just using this software and you can kind of get an appreciation of the powerful impact that I think it is going to make in breast conservation surgery. So I think it's definitely the game changer, and AI is sort of part of the future of medicine and surgery. Is there, I think there's some questions in the chat. I don't know if we have a few minutes to address those. I see one from somebody that says, are there other OCT devices beyond Perimeter's device that exist today? How novel is the company's approach in your opinion? Dr. Tamirisa, do you know the answer to that one?
I don't have
that over to Perimeter.
Yeah, I think that's a great question for Perimeter. I know that it's the device was FDA approved for excised tissue specimens, so including all tissue specimens. And so it's applicable in various areas. In my opinion, this seems to be a novel approach just to our specific part with respect to assessment of the margins, which is kind of a key part of what we do. So I think it is novel from our standpoint in breast surgery.
Yeah.
Yeah, and I think another question here was, assuming you get clear margins using OCT, would radiation therapy still be required or necessary? I think that would depend on what the final pathology showed. We know there's a subset of people who may be able to omit radiation with favorable DCIS or even invasive cancer, depending on their the tumor characteristics, age, and things like that. So it would all eventually depend on OCT, but I mean on your final pathology. But OCT would certainly help to at least establish that negative margin.
Right, I think. I see another question and answer in another box, and it says, are the images analyzed by the radiologist or the surgeon? Great question. The surgeon actually does all of the OCT evaluation. It's live, it's in the operating room with you. You excise the specimen, you would x-ray it to make sure again that you've got your clip and your localization device in there, and then you would just put it on the OCT device and you would scan and look for your margins, and you could know, within minutes whether or not you need to take additional margins because it's close. So there's no involvement of radiology. So this can really be easily applied to sort of all settings. You don't need you don't need a big academic center to be able to do this, which I think is a key feature of it. We're kind of removing the pathologist from being on call. At least in our institution, we send our margins for real-time evaluation, at least for cancer. And then how long do these image analyses take intraoperatively? Yeah, I see Dr. Elmi already answered these questions. I just see it now. I'm sorry, I just didn't read it. I apologize.
Thank you, Dr. Carter. I was just going
just
to add one thing. So yeah, most of the time the surgeons will operate the OCT device and look at the margins, but the pathologists can also do that. And I know that some of the scrub techs are trained to do that as well. So, it just depends how you like to do things in your operating room, but it's pretty versatile, and you can get a lot of people on your team adept with the technology.
Well, thank you everyone for attending today. This was a great session. We really appreciate all of you attending and hope that your questions were answered and you got a sense of what OCT is and what it has to offer. And as mentioned here, you'll receive a replay link via email if you have any other questions that you want to go back and answer. But thank you all. Have a wonderful evening.